Patient is already undergoing implant therapy. So how many have they done already? Once again, lower is completed. Lower is completed. Can I see the panoramic view radiograph? So you're going to mix implant with teeth, or are you going to have separate implant supported FPD and the teeth, whatever is remaining, you're going to keep it as it is. It's just an implant supported FPD in the anterior region, and the rest of the teeth you're planning to keep it in the same way. What about that 3.8, 3.6 region? Are you planning to rehabilitate it? That you find an edentulous area here. Yeah, in that region. Are you planning to do something there? Because normally the implant is seen, the extent of its span is normally limited between first molar to first molar region. If you're going to have a 3.6, 3.8 connected FPD or some kind of a fixed restoration down there, then naturally you expect to have some teeth on top of it as well, right? So your distant limit of that implant should be somewhere in 6 or 7 region, not 6 region. Because you have got a 3.6 to 3.8 connected FPD down there. Otherwise, that area is going to be of no use. So, if possible, you should be going beyond the 2.6, 2.7 region to rehabilitate it with the maximum span. That will give a better occlusal harmony to the patient, right? Because there is 1.7 or 1.8 still in the first quadrant region, right? So what happens is patient will tend to chew more with that side. That's going to cause problem to the other side and the same side as well in many ways. So if you can rehabilitate the entire dentition area uh, by implant supported or whatever it is on both the arches, it helps the TMJ as well. Hmm? Are you planning to extract that 1.8 by any means? Do you have any plan to extract it? That has to go now. Is it already extracted? No, that has to go. So that means that is 1.7, I believe. That's 1.7. Okay, fine. So are you going to rehabilitate that area till 7 or 6? 6 only. 7, you are not going to replace it. So your FPD will be limited to first molar region as such what you see here. Or is that second quadrant implant placed in region of 5 or 6? Somewhere in between 6 and 7. So you can cover up till 6 in that region. So you want to have the same harmony on this side as well. So it should be somewhere at the terminal end of 6. So that you can have some amount of occlusal contact for that 4-7 region as well. Am I right? Okay, so that should be planned because implant should be always planned in such a way that the terminal ends should have an implant. Should not go in for cantilever because more leverage in the occlusal area of the molars compared to the anteriors. So you need to have a terminal and implants placed, then preferably in the canine region. That's once again the one of the corners of corner pillars of the occlusion when it comes to separating the anteriors and posteriors. So canines and distal ends are always some kind of, if possible, a mandatory thing. Hmm. So now we have already placed 3 in the upper. Lowers are not yet loaded, right? You completed placing 5. So beyond this X-ray, you have done implants. Okay. Lowers, have you loaded this? So you've got 3 good implants placed in the lowers. You have got the other molars and teeth which are quite good. You're not going to do anything over there. If required, you might be doing an FPD or an implant in the 3-7 region. which is having a tilted 8. So it's not an easy affair to have an implant in that region. If you really want to have an implant in 3-7 region, then it will be more advisable to extract the 8 and have a 7 there than having an implant placed in between 6 and 7. That's going to create an embrasure in the mesial side of 8, which will definitely invite foot impaction. So if you extract 8 and then place a 7, then it might be of some use to the patient. Otherwise, if you place an implant in that region, that's going to be a foot impaction harboring area, subjected to how much occlusion you get from top. Even otherwise, also lateral foot impaction is possible there. Lateral foot impaction from the buccal mucosa side. That is bound to happen in the area between the, if possible, placed implant on the 7 and the 8. So if you're planning an implant in that 3-7 region, better get 8 extracted and then do it. I think you got the idea, right? So how many have you done so far now? Beyond this X-ray, you have done implants. Okay, which are those implants you have placed? That between 2-6 and 2-7, you have already placed one more. Then even in the 1-1 region, 1-1 region is also done. So that means in the upper quadrant you have placed 3, already 3. Then in the second quadrant you have placed 2. So you are willing for a complete upper complete rehabilitation, right? With how many implants? Presently you have placed 5. So you want one more. And the place which you have found is 1-7 region. 1-7, there is a tooth, I believe. So between 1-5 and 1-7 region, one implant. And you're planning to extract 7 as well. So you can go to the limit of 1-6, 1-7 interdental area, to any limit. Because anyway, you're not going to have a 7 out there. So you don't need to place an implant 1.5 or 2 millimeters away from 7, right? You can place it as much as closer to 7 because you're going to extract 7. Am I right? Okay. So somewhere in 1-6-1-7 region. Okay, that's going to be your sixth implant. Are these 6 implants sufficient for your denture? Space is one aspect because we need maximum number of implants because in implant size, it's always the pericemmental area in your periodontium becomes implant tooth interface in osseointegrated area in implants. So it's always a number of implant that should be given the prime weightage. If number of implants are not sufficient enough, then you give more importance to the diameter of whatever implants you have placed. If diameter is fine or if diameter is deficient or somewhat compromised, then you go in for a longer implants. Diameter plus longer implants are good. But choice over the other, then it is diameter. So what about the diameters which you have already placed? 3.75 to 11.5 in 1.5. Then again 3.75 into 8. That's a shorter implant. Then you have another 3.75 into 8 in the central. Again a shorter implant. Then again 3.75 into 13 into 5. That's quite a long one. But when it came to 2.6, it was again 3.75 into 8. But you have reasonably good diameters you have covered. So because a standard diameter of implant between 3.75 to 4.25 is, they are all considered to be good ones or rather sufficient enough to load it in whichever area it is. But 8 millimeter is definitely a shorter implant or short implants. So in that condition, you're reasonably compensated it with the diameter we can see. Hmm? Not that you're having all perfect implants. So considering these implants, majority of them as shorter ones, the last one which you are going to place should have maximum size. And what kind of a process will you go for this? Mm. Your choices of many, right? Yeah, something that will give some support from the ridge side, not something which will be totally implant bone should be considered. The one which we normally call as hybrid will be good for this because it consider a lesser mm, occlusal load bearing ones. So those things are good. It consists of more acrylic kind of teeth, so which will bear the occlusal load better because it's not going to get apply too much of pressure on the implants, right? So the present condition is you got lower ones that is going to be natural teeth as well as the implant supported FPD. So natural teeth should be opposed by better implants. Am I right? So natural teeth are going to sink more into the periodontal area. Your implant supported FPDs are going to sink very less. Natural teeth sink around 20 to 28 microns into the socket, whereas your implants are going to shrink only or get displaced only 5 microns to its osseointegrated area. So that occlusal disharmony is going to be compensated. You have to do it. So you are going to have implants on the upper arch opposing implant supported FPD in the anterior of the lower and natural teeth in the posterior region. So maximum number of implant is one thing that you should be always considering. That I think you have already done it because you have kept maximum number of implant possible. That is 6. Or if you had added 1 or 2, it would have been better. But I think the bone must be so little that you could not add anything in the anterior region. Oh, canine was an impacted one. So you could not try much in that region as well. So this is the only possible thing what you have already done. So now finishing the three uppers on the first quadrant and two on the second quadrant. Now your plan is to have one implant placed in the 1617 region. So that is the case. So let's see the plan. And we have the clinical view of this area. Can you zoom in? It's this region. You already have an implant in one of those premolar region, right? So which area is this? 1.5. How many millimeter far from this tooth? Any idea? No idea. But is it anyway closer or farther? Like is it in the 1.4 region or 1.5 region? 1.5 region. So it's chance that uh, it could be closer to the molar tooth, right? I mean, closer to 1.6 region. So now the condition is if you are planning to retain this tooth, the outer diameter of the proposed implant should be 1.5 to 2 millimeters away from the nearby tooth, right? So the outer diameter of the proposed implant should have a space of 2 millimeters between the nearby tooth. But here anyway, you're planning to extract this tooth. So you don't have that theory applied here. But naturally, your bone is going to be deficient in the immediate surrounding of 1.7 because you want to extract it. So you cannot have an implant placed as closer to 7. So you can have an implant placed with sufficient bone between the socket and the proposed implant now. So where should the outer surface of the implant come? Where should it come? In comparison or in relation to this 1.7. Hmm? still you consider 1.5 or 2 millimeters away from the socket, so that the future collapse of the socket, because this tooth is mobile, what should I understand? So tooth is mobile, so some amount of collapse of the bone is expected. So to compensate it, place it a bit far away from the socket border. So if you are going to place an implant with its outer diameter 2 millimeters, sparing the present socket area, I mean sparing the bone immediate to the socket area. If the outer diameter need to be 2 millimeters away from the nearby socket area, your lance drill should be how many millimeters away from the present tooth? So it should be 2 millimeter of bone to be spared. Then the radius of the proposed implant, not the diameter, radius. So if you're planning for a 3.75 diameter implant, so roughly it will be around 2 millimeter of its radius, right? So 2 plus 2. So 4 millimeters away from the natural tooth should be okay. Where you're going to start your implant preparation. Osteotomy, you're going to start with lance drill. So lance drill decides the position and angulation of the implant to be placed. Depth is decided by the pilot drill. Rest are all dependent upon the company, what drills they give, what implant size they give, and all those things. But these two things doesn't change. Lance, the preliminary one, is going to decide the position from where you're going to start the osteotomy, the angulation of the proposed implant. Then depth is to be decided by the pilot drill. So, considering all those things, let's see the X-ray. IUPA. Or let's see the panoramic once more. So that's where the present implant is placed, right? When the not the present one, whichever implant you have placed, that is in this present position. So I think you have got sufficient space in between the natural tooth and the implant. You can place it in a quite good amount of a span area. Only the width of the ridge matters. Width we don't know. That we need to know by CBCT or directly while opening the ridge. So again, if you see the socket, is the tooth having a divergent root? Uh, are the roots of this tooth divergent, or is it conical? Maybe it has got some kind of a bend in the tip, but you can call it conical, right? Or fused roots. If it was diverging one with bifurcating in a very obtuse manner, then definitely you would have had a socket that is much more than what you see in a normal view here. You would have had a mesiobuccal root into the area which you're planning an implant of. That is not there, I believe. You got a socket which is harboring a conical root. So there's not going to be much of an interference from the any roots which are possibly divergent if it is in some other case. But here you can see roots which are conical, fused to each other. So when you extract this tooth, you're not going to have a root that might mm, have its root intruded into the socket, I mean, beyond the socket into which your implant is to be placed now. That thing is not there. So that part you're safe. So the roots of this tooth is going to be within the socket, what you see here. So that part is safe. So you can plan an implant in a very comfortable manner here, because your socket is possibly diverging towards its base in the distal area. That is also a good sign. So you have got a very a tent-like bone here in the area where you're planning implant. So 2 millimeters away from the nearby tooth. So first let's calculate the height of the available bone. Because you're comfortable with the position of the implant, which will be definitely the outer diameter of the implant will be one side 3 millimeters away from the nearby implant, the other side sparing 2 millimeters of bone in the socket region. Let's see the height. Height of the available bone. Yeah, that's what an IUPA says. An IUPA in this condition is not going to give you a clear picture because, as you know, it's palate. You cannot place the film exactly in a parallel cone technique. So, natural overlap of the sinus floor is possible here. So, within that limitation, what is the minimum bone you've got? Definitely, this will have an error. Error is definitely there. CBCT will give you a better picture. But in an IUPA, what do you see? You selected three lines. It's good one way you have done because that's the way CBCT also gives you pictures. You have done in your own IUPA, the initial planning which you have done. You have done it as three lines, which corresponds to the implant diameter. Very good. So within that three lines comes your final implant. That is 3 millimeters away from the nearby implant and 2 millimeters away from the nearby tooth. Very good. So what diameter did you get there between these two areas? 4 millimeters. 4 millimeters you could achieve between the 3 from the implant and 2 from the nearby tooth, you could get 4 millimeters. So within that 4 millimeters, you see three different uh, heights of bone here because your sinus floor seems to be not in a flat base, seems to be a bit more convex, right? So the distal end has got around how many millimeters? Roughly 5, or you call it 4. And the middle one? 6. 4, 6, and 8 mm. That is not a very normal thing to find. And I don't think that is the same in the panoramic or in the CBCT. But still, considering this, which will be a size of implant without any kind of a sinus lift? Without sinus lift has to be 4. Because within the within what this IOPA says, it has to be 4 only, right? Otherwise, you have to go in for a sinus floor lift. So, if you need to consider a 4 millimeter implant or with some amount of a sinus lift, still you would search in for a possibility of wider diameter. Yes. So we have got 4 millimeters possible here with the length, with the span. So if 4 millimeter is possible with the width also, then fine. This is a reasonable good size for a molar area. So anything beyond 3.3 is to be utilized here. So 3.75 is a good implant size, which I've already done in the other region. So 3.75 into what is the question now? So diameter, length span wise, 4 is permitted. Width you need to check and find out how much it's going to be. So beyond 3.3 we need here because length is barely minimal length is what is expected. So anything beyond 3.3 for your company size becomes 3.75. There may be company that gives you 3.5. There may be something that gives you 3.6 and 3.65 also. But what you have is 3.75. So you should consider every possibility of placing a diameter of 3.75, considering the molar to be replaced there. And it's going to be a full mouth rehabilitation with FPD. And the distal most area counts very crucial. So in that condition, 3.75 is a desired diameter. Agree to that if width permits. Okay. Now, lengthwise, when you see 4 mm is not at all sufficient. What is the minimum size that you have in the length? Length, you have got 4 point. 4.25 into 6.5. So your 6.5 length starts from 4.25. You don't have a 3.75 into shortest long implants. So if you have to place a 6.5 long implants, then the width has to be 4.25. For a 4.25 diameter implant, you need to have 1.5 millimeter on the buccal and one on the palatal. So that means it is another 2.5 millimeter of extra bone in that region, right? So that makes it 4.25 plus 2.5. 4.25 plus 2 means 6.25 plus another 0.5 millimeter. So that makes it 4.25 plus 2 is 6.25 plus 0.5. So you need more than 7 or 8 millimeter of bone to accommodate a 4.25 millimeter implant, which I don't think is easy to get. So, the picture from what you saw in the clinical side, I don't think that wide ridge is there. So that is going to be a wish of yours, not a possible thing. So considering it to be lesser than that, you have implants ranging between 8 millimeters and beyond it. So 8 millimeter is your shortest possible implant in this case, not 6.5. So 6.5 means you need to have a wider bone area to accommodate the minimum size, which is 4.25. 6.5 in your implant kit, the implant size starts from 6.5 with a minimum diameter of 4.25, not less than that. Normal implant starts in your kit from 3.3, but they don't have a 3.3 into 6.5. They don't have 3.75 into 6.5 as well. It starts from 4.25. So that is again a drawback here. So now the only choice left with you is 3.3 into 8 or 3.75 into 8. So for both the conditions, you need to raise the sinus, lift the sinus. So lifting the sinus, direct or indirect? Yeah. How much of millimeter is permitted in an indirect sinus lift? 4 to 5 is permitted. What about graft? How much of indirect sinus lift is permitted without graft? 2 millimeter. Beyond 2 millimeter, if you're planning it, then it has to be along with graft material. The same thing with jumping space also. When you have horizontal defect or vertical defect, as what we generally call it as jumping distance, again, same rule is applicable there. Beyond 2 millimeter, you need to have bone grafts placed. So indirect sinus lift up to 5 millimeter is possible. The thing is, if you have gone beyond 2, then support it with graft material. So from the panoramic radiograph, what was the height you were assured? 8 to 9 millimeters. Okay, consider this as the final CBCT height. Then beyond this means we need to raise around 4 millimeters of sinus floor to achieve your 8 millimeters. Okay, so how are you going to plan it? You will start with a lance drill. How many millimeters away from the tooth? 4 mm away from the present tooth. Are you going to do it after extracting the tooth or keeping the tooth in place? Why? Absolutely right. You can measure 4 millimeters away from the crust right now itself with the tooth not being there. So you can go in for an extraction. Another thing is you can comfortably place the implant in position, especially with all your handpiece, its head, everything inside. It's going to be a hindrance to your normal placement. So extract it and do it. It will be easier for you to place the lands in the right position. Even the further drills also. So extract it. Then what about incision? Are you going to include your nearby implant in the incision? Nothing wrong in it. When was this placed? 9 months ago. Absolutely fine. So, see, your presently what you want is an exposed bone which will give you sufficient access to it. So you go in for whatever incision is required for you, because in no way you're going to touch this implant on its outer surface or the borders of it or its thread or anything. All you could encounter is its platform area. That is okay. Because even if you expose that area with the vertical incision, you're going to expose the bone alone, not the implant. So, how many millimeters away from your that present tooth will be your distal extension? Hmm? Considering that implant area to be 4, from the nearby tooth to be 2, 6 millimeters away will be your working area. But that's not sufficient, right? Now, if you go in for a ridge size horizontal incision up to 8 millimeter, can you avoid a second vertical incision in an area above the implant? A horizontal incision of 10 millimeters. Hmm? With naturally, you will get a vertical incision in the extraction socket area. So if you open it up, will you be able to avoid a second vertical incision over that implant region? Yeah. If it is yes, then go for it. A longer horizontal incision. So 10 millimeters. 10 millimeters of a horizontal incision with 10 millimeters of a horizontal incision with natural socket area, and then reflect it and confirm the width of the available bone. Minus 2.5 will be your implant diameter possible. If you happen to get 5 millimeter of bone width in your desired area, how will you manage it? The only permitted diameter of implant becomes 2.5 here. How will you manage it? We need to expand the ridge as well. But make sure you're not going to harm the nearby implant. How will you do that? If you expand that region beyond the limit of that bone, definitely that bone is going to crack and your earlier implant is going to face its problem as well. Because it's already integrated implant. If you disturb it, then definitely a further integration is not possible here. That integration has to be kept intact. Still, if you have to expand it, you have to expand it with the implant in place and without any harm to that implant as well or the bone around it. So too much of an expansion and all is not a very favorable or a desirable one. But one advantage of this bone in that region is, what do you think will be the density of that bone? The tooth over there was extracted long ago. So naturally, you'll be expecting a dense bone. But the nearby tooth which you're going to extract today is mobile. So that area is having an inflamed bone uh, proximity. So naturally, that area cannot be anything like a very dense bone as such. It could be D2 or D3 or more towards D3, which is favorable for expansion. But you cannot go in for a 2 millimeter preparation and then a 4.25 millimeter expansion and all. Go in for the minimum expansion possible. Minimum expansion possible in a very slow manner So you have got your split master with you, with which you can expand it very slowly. Not like you shouldn't be going it too fast. Do it very slowly because bone should be given some time for its kneeling as well. It can be manipulated very slowly. You go faster, then bone won't get time to expand as such. It will be cracking. So with that split master, if you're going in for an expansion, do it very slowly. So you have found a place 4 millimeter away from the nearby tooth, or presently it's not the tooth anymore. It's going to be the crest of the socket. From there to 4 millimeters away, your lance drill. How many millimeters will you try the lance drill? It's a sinus. Be careful with the lance drill. It can penetrate directly into it and penetrate and even tear the membrane and go inside. So lance has to be very carefully dealt here. How many millimeters? 2. 2 is okay if you can have an X-ray after that. 3 is fine. Can go up to 3 because you don't have a marking on a lance drill. So 3 millimeters means it's highly, you need to calculate it in your mind. You have to calculate every millimeter that has gone inside and then decide which is 3. Because your blade of the lance drill, what you have is 8 millimeters. So half of that itself becomes 4. So less than that. Then you'll take an X-ray and see whether your position is correct. Then you can also measure on how many millimeters more you can go further with the drill beyond the tip of it. That also can be calculated. Okay, so once that is done, your angulation is fixed. I mean, the position is fixed and the angulation is fixed. Then pilot drill, how many millimeters? According to this IOPA, the center one shows around 6 millimeters that you can go. But according to the panoramic radiograph, you've got a comfortable height of 8 millimeters. So which one will you consider here? Go up till 6. 6. Your first marking in your pilot drill is 6.5. So less than that. 6 millimeters you can comfortably go. But you have to be always careful. Every millimeter you drill inside, search for that possible resistance that you might get. Sinus is not a very easy thing to be penetrated. It's not going to break like a bubble or something, but it offers you some amount of a resistance, totally dependent upon the way that tooth stayed there. It had a palatal root, possibly palatal root, and a divergent two buccal roots it would have had. We don't know. We are not sure about it. We are not seeing the prior X-ray before the extraction of that area. So palatal will be always having some amount of a better bone support, right? So you put it in the right position and try doing it. So up to 6 millimeter of drill is possible, but confirm it with your first lance itself, how many millimeters possible beyond it. If you can comfortably go up to 6 millimeter, go up till 6 millimeters. So you have reached a position of 6 millimeter. Thereafter, if you want to raise it, or if you want to increase the length of the implant, or if you want to increase the length of the drills which you have placed, you are at risk. You are at risk. So you have reached a position wherein you can further go with your expansion screws, which will expand the width of it, as well as that goes into the top area or the apically. It will move into apical area, which will, if at all the sinus comes in its way, definitely that's not going to move further. It will offer your resistance. Whatever it is, don't go further with your smaller drills. Pilot drill, stop it within 6 millimeter. Confirm your X-ray. Confirm with your X-ray how many millimeters is still possible. If it is the limit of the drill, which has already reached the sinus floor, then think about sinus floor elevation. So that has to be done with the osteotomes and mallets. We'll break the floor. We'll break the floor. So further preparation should be limited to increase the diameter within the floor area. So after your pilot drill, you're going to use expanders. So that means 2 is already covered with bilateral. So what are your diameters of implants? Sorry, the expanders. 2.6. So after pilot, 2.6 expanded to 6 millimeters. Right? Then 3. Yeah, 3 into 6. Then 3.4 into 6. So 3.4 into 6, we have expanded it from 2 millimeters. From 2 millimeters, you have reached 3.6. Right? Almost the double of it. All right? 2 millimeters of pilot drill and around 3.6 millimeters of expansion. You have doubled the osteotomy site without drilling it. Double the osteotomy site without drilling it. So bone has expanded here. Otherwise, that's how will it give way. So it has given way to the 3.6 mm expansion your drill, which has not spared the bone in that region. Now imagine what is going to happen with the nearby implant area. It can crack. So going beyond it is a definite issue here. Now we got to place 3.75 diameter implant. So there is always a chance that when you place an implant, the bone can break and it can cause problem to the nearby implant as well. So you've gone double the size of it. Now here comes the clinician's decision of what to do further. What is your perception on that particular area? Can an expansion further with the implant when it goes into place, will it cause much harm or will it cause a fracture line to the area within that bone area or beyond that area connecting the implant is all your decision now. It's a clinician's decision that is going to be a prime matter here or the only matter. If you found that area to be soft enough, less dense, you can go in for an implant here directly. Right? So that means it's going to be 3.6 plus directly implant. Now what about the height? It's only 6 millimeter. That further 2 millimeter floor has to be broken. So you have now a diameter of 3.6, not 2. If you had tried a sinus lift at 2, you will be using smaller diameter osteotomes, which will definitely break and penetrate the sinus floor and the nidarian membrane. But right now, you have expanded it to 3.6. If you're using a 3.5 millimeter diameter osteotome, the chances of breaking the sinus floor is safe, but penetrating the membrane is less. Wider diameter won't penetrate easily. It will definitely break the sinus floor, but it won't penetrate the membrane. So go in for an osteotome of larger diameter, which presently is 3.6. So you can go in for an osteotome with this diameter of 3.4. Yeah, easily go on and easily it can break it. So break the sinus floor and then not to penetrate it further deep because you don't need a preparation beyond the sinus floor. Beyond the sinus floor, you don't need a preparation because you don't have any bone within a cavity. So it's just a floor fracturing, thereafter implant placing. But here, since you need to place it more than, if at all you have to place it more than 2 millimeters, then push graft into the fractured area. Then place the implant. So implant will flush with the bone. That means 8 millimeters of implant, 8 millimeters of complete implant has gone inside. Whatever the sinus has been left will be filled with bone graft on top if it is beyond 2 millimeter. Yeah, beyond 2 millimeter has to be grafted with bone. So if you get around 3 or 4 millimeters as required from here, you need to place bone graft there. So slowly, the implant will slowly push the nidarian membrane up. with the necessary bone grafting in the apical area, and it should be comfortably flushing with the crestal bone region. All right? And then needed suture. If in this process, by any chance, if your distal area, the socket area comes too closer to your implant site, then graft the extraction socket as well. So it is very much needed that you explain this procedure to the patient first, because you need an additional expenditure of sinus lifting and even the graft. So that has to be sorted out. Whether it will happen or not is a different thing. But you need to have spoken to the patient about this entire procedure before you start doing it. Is that okay? I need out. Yeah, you will be preparing it till sinus floor alone. Then increase the diameter. Because as I already mentioned earlier, if you need a longer implant placement, a preparation of the sinus, preparation of an area within the sinus is not at all needed. All you still need is break the floor of it. So preparation maximum till sinus, the depth, then increase the diameter to your desired uh, preparation, then break the sinus floor and enter it and place the implant and come back. It's not that with every drills you need to cross the sinus floor and then do the osteotomy preparation. You break it finally. It's easier. You understood? Okay. Yeah.